Hi, everyone. Sorry we're a few minutes late. Thank you for joining us this evening. This evening's webinar will be given by Dr. John Mangan. He's our spine surgeon here at Rothman Orthopedics, and he sees patients at our Glen Mills, Bluebell, and Limerick office locations. Throughout the presentation, if you have any questions, please feel free to enter them at the Q&A box at the bottom of your screen. Dr. Mangan will take time to answer as many as he can at the end of the presentation. He may not get to all of the questions, but I know he'll do his best to answer as many as possible. So you could take it from here, Dr. Mangan.
Great. Thanks, Natalie. Thanks everybody for joining us. I appreciate it. Like Natalie said, I'm John Mangan. I'm one of the spine surgeons here at Rothman, and I'm going to be talking to everyone tonight about stenosis. What I think you need to know. What is stenosis? A lot of times people come into my office asking that question. So I hope this presentation will help give everybody some clarity on what exactly is stenosis and what causes it. And we'll kind of go through things step by step. Just a little bit of background about myself. I am, local to Philadelphia. I was born and raised in Delaware County. I'm a graduate of the University of Scranton and Geisinger School of Medicine. I trained here at Rothman in orthopedics, and then I went out to the Cleveland Clinic where I did a combined neurosurgical and orthopedic fellowship. And then I've been back at Rothman, and I serve as an assistant professor at Jefferson for orthopedic surgery. I see patients in Glen Mills, in Bluebell, and in Limerick. I operate at a multitude of different locations, Riddle, Physicians Care Hospital out in Limerick, Chester County Hospital, and Jefferson in the city. So that's just a little bit of background about me, but now we'll get into the reason that everybody's here, which is so we can talk about what is stenosis. So we're going to define stenosis. We're going to talk about the different symptoms, the different causes, and then we can talk about treatments. And then I'm happy to answer questions at the end so that we can kind of hopefully give some clarity to the topic for everybody. So what is stenosis? So stenosis, quite simply, is the abnormal narrowing of the spinal canal. And so what happens is in all of us in our low backs, we're going to be talking mostly about lumbar stenosis today. We have nerves that come down. Our spinal cord actually ends at the lower part of our chest, of our rib cage, or the upper part of our lumbar spine. And then after we have the end of our spinal cord, we start to have the nerve roots or the spinal nerves, as you can see in this picture. And what happens in spinal stenosis is for a multitude of different reasons, the spinal canal, which is the tube that the nerves live in, gets narrowed. And I often will use the analogy of it's like an old pipe that over time things just build up on the inside, and the inside of that pipe, that opening, gets narrow and narrow over time. And in humans and patients, this can happen abruptly, that people can get kind of acute spinal stenosis if they have a large disc herniation. And most of the time it happens slowly over time. People develop arthritis and degenerative disc disease, and it causes this narrowing or pinching of the spine. If we look at the picture on the right, I've tried to outline in red the spinal canal. This is a picture looking at a patient from the side. So where the words are on the page or to the left of the screen is where the front of the patient is. The back of the patient is to the right over here. And the tip of the spinal cord is at the bottom of the red arrow. We call that the conus. And then down below here, these lines represent the spinal nerves that travel down. I've outlined the spinal canal, which is the bony tube that the nerves live in, and that's outlined by these red lines. And if we track this down, in this patient, you can see all of a sudden at the L4-5 level, which is the second from the bottom level of the back, there's this big thing here. This is a big disc herniation, and you can see that all of a sudden the two red lines have become much closer together than they are at any other part in the canal. And this is kind of what spinal stenosis looks like. And we'll go through more pictures of this in a few minutes. But this narrowing or pinching of the nerves gives people a multitude of symptoms that we'll talk about. And so the view that we just looked at was called a sagittal view, or it's a side view of the patient. That's one important way to look at the area for the nerves. This is another way that we look at patients, and I'll often say to patients, this is the deli slicer view. So before we were looking at patients from a side view, this is if we're looking at the patient, we're looking kind of like up the tube of the spinal canal. So this is something where the nerves are getting looked at up and down. And so this is a cross section or an axial view. On the left-hand side here, you can see this big red circle that's full of white That white is the spinal fluid that protects and bathes the nerves, and the little dots in the back of the circle are the nerves that actually go to our legs and give us sensation and strength. And uh, this is what a normal axial view of a non-stenotic spine looks like on the left-hand side of our screen. On the right-hand side of our screen, you can see where I've outlined in red. This is a picture of spinal stenosis. This is all of that big white circular area has gotten squished into this little oval here. And this is where all of those nerves that should have been living in this big kind of open space have gotten squished. And, in this particular patient, why that is because they've developed significant arthritis in the joints in the back of the spine. These are the facet joints, which are the joints at every spinal level in the back. And this dark part here, this black area, is the ligamentum flavum. And normal arthritis that develops in patients and humans is that patients will develop arthritis within those joints, and they will cause thickening of the ligament there. And those two things in combination with plus or minus a disc bulge or disc herniation will cause that this surface area, this circumference of that canal to get smaller and smaller and push on those nerves, which starts to give patients symptoms. So what are the symptoms that patients get with spinal stenosis? So the main thing that people come into my office uh, to be evaluated for is pain, right? So some patients will get pain in their low back. They can get numbness and tingling in their legs. In severe cases, patients will show up and have weakness or a deficit in their legs. And so these are the kind of the main symptoms, and we'll go through these each in a little bit more detail that people will get. And the common or the classic scenario of symptoms that people will have is something called neurogenic claudication. And what neurogenic claudication is, it's really the constellation of symptoms that go along with severe pinching or squeezing of the nerves in the low back. People will often say, I don't really have a lot of leg pain, but I have a ton of buttock pain or gluteal pain. They can get pain down the legs that radiates all the way down the leg. And often people will say, I have this heaviness in my legs. I feel like I'm dragging sandbags instead of being able to walk smoothly. And typically, I'll ask patients, how far could you walk a year or two ago? And has that changed? And patients with spinal stenosis will often say, like, I could walk 3 miles last year. I can walk, a half a mile now before my legs are just so fatigued and heavy and tired um, that I just can't walk that far anymore. And so, again, that difficulty walking is one of the hallmark signs of spinal stenosis. People will often find that they're bent forward. This is something that either patients will recognize themselves, or more often than not, friend family will say, you're starting to hunch over a little bit, you're starting to lean forward. And the reason that is, we'll get into in a second, but as those nerves get more and more pinched, our body reactively starts to lean forward and we start to bend forward to try to stretch out some of that ligament that I mentioned earlier that gets tight. And that helps to give more space to the nerve. So people are more comfortable when they're leaning forward. Um, Pain down the legs, like I said, it may or may not happen. It could be mostly in the buttocks. It could be all the way down the legs. And some people will have no back pain at all and still have these symptoms, and they can still have spinal stenosis, or they could have very severe stenosis or very severe back pain and also have spinal stenosis. Patients find that standing up straight can be very bothersome for them. That's why they start having that leaning forward posture. And they find that if they sit down and take a break, usually their symptoms get better while sitting and they're worse while standing and walking. This is the classic sign of spinal stenosis. I often joke this is really the only thing that they teach you about spinal stenosis, unless you go into spinal diseases and spinal medicine in medical school, is that the shopping cart sign is one of the classic signs that people will say, or symptoms that they'll say when they have spinal stenosis. And this is because when we push a shopping cart or we're pushing any kind of object, we're leaning forward. So it's giving us balance by leaning forward, and it's allowing us to stretch out our low backs. And as I mentioned before, what happens is the ligamentum flavum starts to stretch out and thin out. And so it creates more space for the nerves as we lean forward, and patients feel much better when they're pushing a shopping cart. So often that same patient that will tell me that they can't walk like they used to, I'll ask them about going to the grocery store, and they'll say, well, as long as I get to push the cart, I can make it through the whole grocery store. I can get all my groceries and I feel fine. But when I leave the cart and go start trying to walk back to my vehicle, that's when my symptoms start coming back again because at that point they've lost that forward posture and that leaning from the shopping cart, and their symptoms start to come back as they're walking more extended. Radiculopathy. So this can go along with stenosis, and sometimes this is really the only presenting symptom of stenosis. But radiculopathy is the formal term for what most people refer to as sciatica. Sciatica is that pinched nerve that goes down the leg. Classically, people describe sciatica as an S1 radiculopathy, so in the back of the thigh, in the back of the buttock, down to the bottom of the foot or the lateral aspect of the foot. But really, radiculopathy or that phrase can be used for any of the spinal nerves that can give you pain in the front of your leg or the side of your leg. And so when a nerve gets pinched, whether it's from stenosis of the whole canal or just part of the canal, when somebody gets like a herniated disc that causes a pinched nerve in isolation, the pain will usually follow the dermatome or the area that that nerve travels. So people will find pain down the leg in a certain pattern. And when we're looking at people's imaging and we're looking at x-rays and MRIs, we're trying to make sure that their pain pattern matches their imaging because we want to make sure that we're identifying the proper nerve that's getting pinched or irritated. And then that way we can treat it more effectively, obviously. So patients can have pain in their back when they have radiculopathy. And it can be associated with stenosis, although it doesn't have to be with severe central stenosis. Patients can have radiculopathy or that sciatica as just a presenting sign of their underlying stenosis. So what causes this? Why do we get this? So it's in most people, this is a degenerative process. So this occurs over time because we start to wear out our normal healthy tissue in our backs just from age. I often will say to patients, the arthritis in the back it's a disease of the living, right? It happens, in almost everybody. If you live long enough, it will get you at some point. And there's ways to obviously try to promote healthy habits to try to prevent or minimize the amount of wear and tear that we have in our low backs. But over time, in most of us, the discs will start to dry out and get thin. And as they thin, we start to lose that normal motion of our vertebrae. And so we start to develop more arthritis in the back itself. In the pictures here on the side, the picture on the top left, this is a normal, healthy looking back where the discs are in between these boxes here. So the box represents what's called the vertebral body, and the kind of the oval looking structures in between them are the discs. And the discs in these pictures look fairly normal. There's a good space in between them. The signal of the disc is nice and healthy. We can see in behind the vertebral bodies into the spinal canal, and there's a lot of white fluid that looks fairly symmetric all the way up and down, like there's no spinal stenosis. Now, in comparison, this is an extreme picture, but this is a picture on the right of somebody who's had a significant amount of degenerative disc disease and wearing out of the discs of their low back. And you can see in this picture on the right-hand side, there's very little space in between the boxes, which are now not, perfect looking, smooth boxes. They look more like rectangles. They can look a little scraggly. And you have these protruding dark areas of what looks like the disc material. These are herniated discs or bulging discs pushing into the spinal canal. And you can see that you don't see that smooth, even line of spinal fluid anymore. And this is just the natural history of spinal stenosis, albeit an extreme case. This picture on the bottom here, I think, really shows us what those facet joints that I was showing on the deli slice or the axial view of the spine. And so these are what the facet joints look like. And what they are joints that rotate in our back to give us motion. And they're the same as hips and knees. Over time, they will wear out and they'll get bone spurs. They can get cysts that grow out of them. And what happens is when you develop arthritis in these facet joints, they get bigger and they start to take up room that belongs for the nerves. And so over time, this arthritis just encroaches more and more on the nerves and can cause pinching and pain. And one of the other reasons that's not really on this picture, but we'll talk about it later, is a disc herniation. In some patients, if you have a large enough disc herniation, you can develop radiculopathy, that's sciatica down the leg. The patients will also develop fairly acute symptoms of spinal stenosis where they feel like their legs are heavy and they have difficulty walking. It's because the disc herniation is really taking up a lot of the space of their spinal canal. And this is just a refresher of what is spinal stenosis. It's the abnormal narrowing of the spinal canal. So this is the area of abnormality, right? This is the area where the canal has gotten thinned, and everywhere else you can see it's nice and wide, and you have all that white fluid protecting the nerves. But here you can see everything's getting pinched, and this is the picture of spinal stenosis. I mentioned earlier disc herniations. Again, some people can have large disc herniations that will occupy a lot of the volume of the canal, and they can give them sciatica or radiculopathy, but they can also give symptoms of stenosis or neurogenic claudication, which doesn't have to have that searing leg pain with it, but it can have the buttock pain, the heaviness, the difficulty walking. In this picture here, the disc herniation is the area where this star is, and you can see that it's pushing on this structure behind that. And this is the nerve sac. This is the thecal sac here where all the nerves are, and it should be able to take up all of this space, but everything is getting kind of squished now between the bones and the ligament in the back and this big disc herniation. And this circle, this oval in the front here, is that cross-sectional view of the disc herniation. One of the other common reasons that people will develop spinal stenosis is that they develop instability in the low back at one bone or one level, excuse me, or multiple. This is fairly common. Around 7% of the population will develop this over time. And it develops relatively young. Some patients will develop it in their 40s, 50s, and 60s. And what it does is people will develop an offset or a shift in one of the bones. It's commonly at the L4-5 level or the L5-S1 level. And if you look at the picture on the screen here, if you kind of block off that bottom level where the bottom red line is, and you just look at all the bones above that, you can draw a line straight down the back of these boxes, and they'll all line up with that top red line. But if we go to try to connect the one below that, you can see that they don't line up anymore. And this is called a spondylolisthesis, and it's an abnormal alignment and mobility of the bones where the bone starts to shift back and forth out of place. And what this causes is it causes narrowing of the spinal canal because now the bones, instead of lining up in a circle, they're off. So the center area gets narrowed just because of the bones shifting, as well as it causes increased arthritis in the facet joints and additional ligamentum flavum as your body is trying to stop that motion. And all this does is end up causing more and more pinching or narrowing of the tunnel for the nerves. So if you come to see me or one of our other providers for spinal stenosis, what exactly happens? So, a good history always, a good examination always starts with a good history and a physical exam. So I like to see patients walk. I want to see how they walk into the room, how they're walking around, and hear when this started, how long it's been going on for, and what exactly the symptoms are. Often I have patients try to trace out their pain, whether it's pointing to it in their back or pointing to where it goes down their legs. We test each of the muscle groups in the leg to make sure that every muscle is strong. And then I think one of the most important things of this is actually looking for other causes of what could be the cause of a patient's symptoms besides their back. So making sure that people don't have hip arthritis or trochanteric bursitis or tendonitis, which is inflammation of the tissues around the hips, which can mimic some radicular symptoms. So really, we're trying to rule out different things to make sure that we're not missing something and something isn't mimicking lumbar or spinal disease. We get x-rays on everybody. And the reason we get x-rays is because they show us the alignment of the bones while people are standing. And so this is a very important tool for understanding exactly what's going on in somebody's back. An MRI tells us one part of the story, and we'll talk about that in a second. But really, x-ray tells us how healthy the discs are because we can tell how far the bones are spread apart. In this picture on the right here, again, the boxes represent, this is the vertebral body, the anterior bone of the spinal column. And the disc is the space in between the bones, in between these boxes in the front. So you can't see the disc itself with the material of it, but you can get a sense of how healthy the discs are based on the space in between the bones. I'm also looking at the alignment for patients. So one of the things that I think is critical is getting x-rays standing up, because what happens often is that patients can have instability or that spondylolisthesis we just talked about, and the bone can shift out of place. But sometimes if it's very mobile, when they lay down, the bone will shift back in and it'll look like it's almost normal. And so when patients get an MRI, where you're laying flat, then it may not show the instability at that level, and it may undercall the amount of pinching of the nerves or the stenosis that's there because it looks more normal because it's shifted back into place temporarily. And that tends to be why patients' symptoms get worse with standing and walking than they do with sitting or lying. Um, and patients will often ask, why don't we get an MRI on everybody as soon as they come in? One is because the X-rays tell us a lot of the story, and can really help us figure out what's going on. And we find a lot of issues in patients that aren't necessarily causing symptoms. And this has been pretty well studied in the spine literature that if we got MRIs on the majority of people, we would find things that are probably asymptomatic, which may lead us to chasing things that aren't necessarily helping patients. Um, and so this was a study by Dr. Bowden. This is kind of one of the classic studies where he looked at patients that said, I've never had any leg pain, I've never had any back pain, I can walk as far as I want. And he, evaluated patients over 60, and out of those patients, 57% of them had an abnormal MRI, even though they said they've never had symptoms in their life. 21% of those patients had spinal stenosis, but it just wasn't symptomatic. Patients that are younger than 60 in that study, a third of them had an abnormal MRI, and even patients between the age of 20 and 39, 35% of them had an abnormal MRI. They had at least a disc bulge on that study. So that's one of the reasons we don't rush to get an MRI on everybody unless they have certain symptoms that warrant it, like weakness or bowel and bladder issues. So just as I said, so an MRI is typically warranted when symptoms persist. So, we try to treat patients conservatively first with therapy and medications. If their symptoms don't get better, then that's when we talk about getting an MRI. If patients come in with weakness, then I will, pretty much order an MRI right away so that we can evaluate the cause of their weakness. And then there's a syndrome called cauda equina syndrome, which is when patients develop usually acute severe spinal stenosis that causes bowel and bladder incontinence and saddle anesthesia. If those things develop, those are things that we send patients immediately to the emergency room for because they can be a surgical emergency and they need to be evaluated quickly. But for the majority of patients, once the symptoms are persistent and we've kind of failed some initial basic treatments, that's when we'll typically get an MRI to see what's going on. So how do we treat this? So, it's really a team-based approach, and I think that's one of the beauties of working here at Rothman is that we have great physical therapists, great non-operative spine providers, and surgeons that are able to take care of patients through the whole spectrum of their spinal stenosis and their symptoms. And so, we always start conservative. So, we usually start with physical therapy and some medications. If we are not doing well in that regard, we have non-operative providers that can talk about different medications as well as injections to try to alleviate some of the symptoms. And then if those treatments fail to make patients symptom-free or improved enough that they're tolerable, then that's when we usually will talk about surgery. So, as I mentioned, the first line treatment is typically an anti-inflammatory medicine. For patients that are able to take them, I'll usually prescribe either a prescription ibuprofen or something called Mobic, which is in the same class of medications, or steroids to try to help alleviate some of the inflammation around the nerves, try to make symptoms better. We usually start with physical therapy because stretching and core strengthening can help alleviate symptoms. And the good news for everybody out there is that more than 90% of patients will actually undergo the anti-inflammatory medications and the steroids and actually feel a lot better, and they won't progress to any other treatments. There are some patients who undergo the therapy and the medications. They still have symptoms and they undergo steroid injections. For me, steroid injections are both therapeutic and diagnostic. So I use them to help kind of confirm our diagnosis that we're treating the right thing. It also helps to alleviate symptoms. And it helps us, again, to figure out if things don't keep getting better, are we treating the right problem? And then the last treatment would be surgery. So the goal of surgery when we treat spinal stenosis is to make more room for the nerves. And so there's a multitude of different treatments that we can use surgically to fix that. One of which would be a laminectomy. And a laminectomy is kind of the standard tried and true way of opening up the spinal canal and opening up the room for the nerves. And the way we do that, as you can see on this picture here, we go in and we remove a portion of the bone, which is called the lamina and the spinous process. and we remove the ligamentum flavum, which is the thick ligament that is gets thick in stenosis, like we showed earlier, and we remove that to make more room for the nerves, so that tight compression on the nerves is opened up, and the nerves can look more like they did in that picture on the left-hand side of the axial view, where they have a lot of white fluid and space in between them. For patients that have instability and those bones have shifted out of place, that's when we talk about a lumbar decompression and fusion. And so the indication or the reason to have that surgery is that the spinal stenosis is coming from an area where that bone is shifting out of place. And if we don't stabilize that area and that bone continues to shift, patient's symptoms will often come back. So we fuse that area so it can't have that motion to cause recurrent issues in stenosis. Or sometimes if we have to remove so much bone, a lumbar fusion is indicated so that patients don't develop that instability or that motion once surgery is done. And this is what a lumbar fusion looks like traditionally, with rods and screws in the back that hold everything together. And then over time, the bones will grow together, and then they'll move as one unit. And those rods and screws at that point are really not doing anything. They're just in there initially to act like a cast to let the bones heal and grow together. So they're kind of superfluous at that point. And the last option for treating stenosis is what's called a microdiscectomy. So once patients, have failed those non-operative treatments, microdiscectomy is typically used for patients that have that sciatica or that radiculopathy, where the pain is going down the legs. But sometimes we have patients that have fairly large disc herniations that are off to one side, and we can perform what's called a discectomy. And what that is a smaller version of the laminectomy, where I remove some bone and I remove some ligament, and I'm able to get into the spinal canal, move the nerves out of the way, and take out a large portion of disc material that is causing the problem. So when we do these surgeries, we're not taking out the healthy disc that patients need. We're taking out the part that's in the canal that shouldn't be there, and that is what's causing the symptoms. So that's kind of my brief overview of spinal stenosis. I'm happy to take anybody's questions and elaborate on any of that if anybody has a particular question. Thank you.
So the first question was can stenosis cause neuropathy?
Yeah, so stenosis can cause numbness and tingling in the feet, absolutely. And that can be there's many causes of neuropathy. It can be an issue with the nerve itself in the leg, but it can also be from spinal stenosis with that nerve getting pinched. It can give you numbness in one part of your leg or both feet. That's a fairly common symptom of stenosis.
The next question says, can stenosis be the cause of numbness in my right foot? If so, at which level? Like
Uh,
L.
Yeah, so that's a good question. Without knowing where the numbness is in your foot, it's hard to know what nerve root is actually getting pinched. But yes, stenosis can cause numbness in the foot. If it's the L5 nerve, people will feel it across the top of their foot into their big toe. If it's the S1 nerve, people will find it on the bottom of their foot or towards the small toe. And typically the small toe and the one next to it will get numb with an S1 radiculopathy. And in stenosis, you can have more than one nerve pinched. So you can have all of those symptoms at the same time.
Thank you. Next question says, I have stenosis diagnosed last year and I had a steroid shot. I could walk after the shot, but my calves and foot toes are tingling and numb. Should I get another steroid shot to make this better?
I think you could certainly try it. I mean, I think if the walking is better, it's not an unreasonable question to ask are you another candidate for it? Sometimes I feel like the injections don't um, get the numbness and tingling better, but sometimes they do. But as the stenosis progresses over time, the injection may, not work as well, and you may get more numbness and tingling.
Thank you.
Mhm.
Um, Someone asked, is PT usually helpful? I know you kind of touched on this.
Yeah, PT, I do think it's helpful. Does it change uh, the way that the MRI looks? No. But again, we treat people, we don't treat pictures. So, if your symptoms are persistent, after physical therapy, that's when we talk about the other things. But if your symptoms go away after therapy with stretching and strengthening of the core, usually we'll just watch this.
Thank you. Is spondylosis associated with stenosis?
So, there's two words that sound familiar, so I'll answer that question for both of them. Um, the Spondylosis is that arthritis that we develop. Those facet joints that we looked at, those are what get arthritic, and the disc starting to wear out. We kind of refer to that generally as spondylitis, or spondylosis, excuse me. Spondylolysis is when people will develop pars fractures, which is the pars is part of the joints in between the levels of our spine. And over time, some people can develop fractures in these areas. It typically happens when we're adolescents, but it usually presents itself later in life. And that's when people will break the bone that holds the two levels from slipping on each other, and they'll develop that spondylolisthesis that I just talked about, and that can lead to foraminal or central stenosis.
Thank you. There's a couple questions about the ablation procedure. Um, can you explain what an ablation is and if it helps stenosis?
Yeah, so ablations do not help stenosis. And so that's actually something I see fairly commonly is that people will come in and ask about ablations or burning the nerves, and that really treats low back pain. That doesn't help the stenosis. That is treating the facet joints that we showed earlier that get arthritic. Ablations are aimed at trying to take away your ability to feel the arthritis that you have in those little facet joints, which can be very effective for some back pain, but it will not help the stenosis or the leg pain or the heaviness in the legs. It would just help back pain.
Thank you. Can you comment on a procedure sometimes called microplaning? I think that's what it is. That removes arthritic material, compressing the cord, and also can it be used for sacral stenosis?
Um, I can't say that I know specifically what you're asking about with microplaning in that regard. Uh, Typically, there's people will do what's called a laminoforaminotomy or hemilaminectomy, which is a more minimally invasive procedure that I and other surgeons will perform to try to alleviate spinal stenosis without having to remove as much of the full lamina. And it can be very effective at treating stenosis in the lumbar spine as well as at the lumbosacral junction.
Thank you. Is there any link between osteoporosis and stenosis?
Um, Not directly. Osteoporosis can cause fractures that uh, can sometimes cause bony spinal stenosis if bones push back into the spinal canal. And they can change your alignment, which may predispose patients to spinal stenosis, but there's no direct cause of stenosis and osteoporosis.
How do your approaches to cervical stenosis differ from those for lumbar stenosis?
Sure. So cervical stenosis is a very interesting topic, and I chose just to talk about lumbar today. But when we talk about cervical stenosis, there's a lot of different options when we talk about treating it. And cervical stenosis in the neck is a much different problem than in the low back. So people with cervical stenosis or stenosis in the neck, they develop something called myelopathy typically. And they can develop that radiculopathy, that sciatica with pain in the arms. And so I really try to treat each individual patient based on what their imaging looks like, their pathology, as well as the patient as an individual. Sometimes we'll treat that stenosis from the front of the neck, where we talk about disc replacement in kind of limited fashion, or what's called an anterior cervical discectomy, or from a back of the neck approach or posterior approach. And then there's something called a laminoplasty, which some patients do very well with, which is a motion sparing way to treat stenosis in the neck, or a laminectomy infusion. And it all depends on patient's alignment and the severity and the cause of the stenosis in their neck.
Thank you. Lots of questions coming in.
Perfect.
Um, Another question. Do you or any other surgeon at Rothman do Total posterior spine surgery instead of the usual fusion surgery.
Um, Total posterior. So, do the TOPS procedure. I'm sorry.
I'm sorry.
No, that's okay. So, none of us at this point do the TOPS procedure. The the TOPS is an interesting concept, and there's only very few surgeons in the whole Philadelphia area that do it. I have some experience in it from when I was at Cleveland Clinic. Um, and in right patients, it may be a good solution. I don't think we have the best long-term data at this point that I'm doing it. But no, none of us here do it right now.
Thank you. Next question. Can an EMG test help identify the particular disc or area causing difficulty walking or other symptoms?
Yeah, it can be helpful in certain patients. I think it's a very helpful procedure. I tend to use an EMG for certain reasons. So if somebody comes in with weakness and I don't think it necessarily matches their imaging, I think an EMG is a great test. If somebody comes in with weakness, and maybe their imaging matches, but maybe we're concerned that something else is going on, I think an EMG is a great test. Or if somebody doesn't have the response that I expect from injections and things like that, that can be helpful. Um, but I don't I get them certainly, fairly frequently, but I kind of reserve them for certain patients. And most of the time it's not necessary to diagnose um, the spinal stenosis or their patient's sciatica radiculopathy.
Thank you. A couple questions about the mild procedure. Um, somebody asked their thoughts on it. Somebody said that they had it, it worked for a while, but now they're back where they were. Does that indicate anything about this person's condition or prospects?
Yeah, so the mild procedure, is kind of an interesting topic, and what it is usually somebody going in and removing a small portion of that ligament, the ligamentum flavum that we discussed before. Um, and so, really taking away some of that ligament through the little cannula that they do it through, it may give patients a temporary relief because they take away some of that ligament, but that ligament is not removed enough that I think it gives people lasting relief. Um, and I think typically they'll also give patients a steroid shot at the same time, which is why there's sometimes uh, a brief time period where patients feel better until it comes back. So I think it's uh, in certain patients it's a great option, but I think those patients are not very common.
Thank you. A couple questions about spinal stenosis interfering with a total knee replacement. Can it interfere with that?
So, I've had a handful of patients that have had total knees that have not felt like they got better from their joint replacement. And if they have spinal stenosis and they have some narrowing of particular nerves in the back, it can give patients uh, pain that mimics almost knee pain. Usually, it radiates a little bit more up and down the leg than the knee itself. And I've had patients where I've gone in and treated their spinal stenosis and their knee symptoms and the leg symptoms have gotten better. Now, the hard part is if the total knee itself is painful, I may get rid of the radiating pain, but if the knee itself is also causing problems, that wouldn't get better from surgery, if that makes sense. But if there is an underlying back issue, we can alleviate those symptoms. And there's different ways I work through trying to make sure that the back is causing the symptoms that patients are feeling.
Thank you. This person says, my husband has stopped walking and he has severe spinal stenosis. Can surgery help him regain his ability to walk?
So, that's a hard question to answer without, seeing his images and knowing kind of what's going on. It is, if your husband is, the strength in his legs is there, he just feels like he can't move anymore because he has, severe heaviness and pain in them, then yes, that's the case. That it may be helpful. But that question's pretty individual. And so it's hard for me to say yes or no. But surgery in the right situation, even in that kind of situation, could be helpful.
What is the recovery time for after surgery? Can the patient return to normal life activities? And what's the recovery time like?
Yeah, so I tell pretty much I tell all my patients that the short-term recovery from any one of these surgeries in the low back is or in the neck for that part is 3 months. For me, I let patients start to resume normal activities as long as they're feeling good, and everything looks good on imaging at 3 months. I limit everybody to lifting no more than 10 pounds for 3 months, and no excessive twisting of the low back or the neck, depending on what we operated on, for 3 months after surgery. Um, for the first 2 weeks, I like patients to just walk gently around their home, and gently outside a little bit. After we see patients at 2 weeks, and they're feeling well, I'll start letting them walk more. Um, and then going back to work really depends on what the occupation is. I have some patients that go back a week or two after surgery, especially if they can work from home and it's remote. Whereas then I have laborers that may be out for 2 months or so before I'll let them go back uh, either in a limited fashion or full duty, depending on what surgery they had.
Thank you. How does how does lumbar stenosis compare to thoracic stenosis, T4, T5? This person says they've had an ablation and three epidurals, but not fixed yet.
So thoracic stenosis is a different problem, and more closely mimics the cervical stenosis that I mentioned earlier. So when patients get compression of their spinal cord rather than the nerves that we talked about in the beginning of this lecture, um, the spinal cord can start to get dysfunctional, and so we call that syndrome when the spinal cord starts to get affected myelopathy. And myelopathy gives people the symptoms where their balance starts to be off. They can develop some abnormal reflexes, and they feel like they're staggering and they have a fear of falling. When it's in the neck, it can also cause hand symptoms where patients feel that their hands don't work quite as well as they used to, or they have numbness and tingling in them. And so, um, ablations for stenosis in the thoracic spine, if your spinal cord is getting pushed on and you're having some balance issues, that's not a good treatment for it. If it's pain there, that's a reasonable treatment for it. But if you're having symptoms of balance issues or numbness in your legs and things like that, that's usually something that we talk about taking the pressure off the spinal cord, if it's really significant sooner rather than later, because that is a problem that can progress and cause worsening neurologic function.
Thank you. Will weight loss or improving your posture help stenosis?
Both of those things, I tell patients all the time, both of those things are great for your life overall. So I obviously highly recommend them. It may make your back feel better. It may help your symptoms to feel better. It won't change your imaging. It won't change the way the pictures look of how compressed the nerves are. But again, we treat the patients, not the images. So if losing weight and working on your posture and being more active helps your symptoms to get better, then that's a great treatment.
Thank you. Question on injections. This person says, who do you recommend for injections? Interventional physiatrists, pain management physicians, spine surgeons? Is there any difference in the type of injections that they give?
So good question. Yeah. So here all of our physiatrists are the injections for our group, and they do a great job because that's their main job is that they are the injection experts for us. And so I always kind of say to patients like I trust my partners, if that makes sense. And so that's who I usually send all of our patients for injections for. Pain management doctors, obviously, that's what they do as well, and they can do injections well. And same thing with anesthesia doctors, or there are certain spine surgeons that will do their own injections. For me, I like using our physiatrists because they do this every week. It's repetitive for them. I can see where they put the injection, which I think is really helpful for me as a surgeon, especially because some people can have what's called transitional anatomy. So not everybody develops just like the textbooks say that we do. And so, especially in somebody that has maybe a little bit of an atypical anatomy, if we're talking surgical intervention, I'll usually send patients for a shot as that kind of like diagnostic tool. And then I will try to look at the picture of where the doctor put the medication that helped. so that I can make sure that we're talking about the right level and we can kind of make sure we're honing in on the right thing.
Thank you. This person has said that they have been told they have scoliosis of the spine, and can anything be done for that?
Yeah. So again, that's a very individualized question. Yeah, yes, we can treat scoliosis, and we can straighten the spine, or we can stabilize the spine. Probably in the vast majority of patients with scoliosis, uh, we don't need to treat it, and so scoliosis can be treated. It can be effectively treated, but in the majority of patients, we typically observe it and make sure it's not progressing. Now, scoliosis can also cause some narrowing of the nerve tunnels, which can give patients symptoms. And in that case, sometimes we have to treat it. But what that treatment is really depends on the patient's anatomy, the degree of their curve, and a lot of specific factors.
Thank you. How long does a steroid shot work, and will the pain return in a certain amount of time?
That's a great question. So, and one that I get asked a lot. So, the steroid shots, I usually tell patients are fairly low risk and fairly high reward. So, some patients they last months, sometimes even years, and patients feel much better after them. Other patients, I feel like they don't do anything for it at all, and other patients, it's somewhere in between. It lasts weeks to months, sometimes days to weeks. So, it's pretty different in patient to patient. So. I try not to give people what the average is. Our hope is that each injection will last a patient about 3 months. Some patients exceed that. Some patients don't quite get that far as much of relief from them.
Thank you. Can you go back to jogging after spinal surgery, like a laminectomy?
Yes. Yeah, I let the other question I get is jogging, golfing, going to the gym. All of those things I let patients go back to after surgery. I think, the reason to have surgery is to get back to the activities that patients want to do. I think, if you're going to be, at least in my mind, the way I think about it is you're having an intervention to fix a problem so you can get on with your life and do other things besides think about your back. And so, yes, yeah, I guess in short is I would let somebody go back to jogging and all those things.
Thank you. Can you discuss, I don't know if I'm saying this right, foraminal, for, I'm sorry.
What is a foraminotomy?
Foraminotomy and foraminal stenosis, the definition
Yeah,
of
so
that.
yep, I can talk
Thank
about
you.
all that stuff. So yeah, I got you. So what is foraminal stenosis? And then I'll get into a foraminotomy in a second. So foraminal stenosis is narrowing of the nerve tunnel as it leaves. And so if you think about the picture that I showed, there is the big main channel, the big tube of the spine, and then off the sides of that tunnel are little exits for the nerves. And I commonly will tell patients, like, if you think about a highway, patients either get stenosis or pinching of the nerves in the main highway, which is what we talked about mostly today, and that's pinching of all of the nerves, or you can get stenosis, you hit traffic on the exit where you're trying to leave, and that's foraminal stenosis, where the nerve root is leaving. And the foramen is, it's the little kind of side tube where the nerve is leaving, and patients can develop disc herniations in there, or they can have arthritis develop into that area, which then narrows the exit for that nerve, and patients can get pretty bad radiculopathy or sciatica down the leg from that. Um, and sometimes, the height of the nerve tunnel, so the distance between the two bones that make up the floor and the roof of it, the height of that is set by the disc. And so as that disc wears out in all of us, sometimes the roof will come right down onto the nerve root, and patients will get pretty significant symptoms down the leg. One of the possible treatments for that is what's called a foraminotomy, where if somebody has, you can have central stenosis as well as foraminal stenosis that we treat with, a laminectomy and a foraminotomy, or you can have foraminal stenosis and not much central stenosis. We can treat that with a foraminotomy as well. And that's where we go in there and we essentially try to remove the arthritis around that nerve root to make more room for it and take away that pain.
Thank you. Can scar tissue in the groin or hip area exacerbate the pain of stenosis?
Um, so patients with hip problems can have worsening back pain, or they can feel it in their backs. I wouldn't say that scar tissue in those areas would make the stenosis worse, but it certainly could make the symptoms of stenosis more symptomatic.
Thank you. I think we have time for a couple more questions. A lot came in, so apologize if we don't get to all of them. Um, do you recommend chiropractic procedures for spondylolisthesis? Am I saying that correctly?
Let me see where that question is.
It's the last one.
Last one. Um, I think chiropractic care is for that kind of an issue is fine to try if you have a chiropractor that you like. And that, I'm not a big fan of the large manipulations of them, but I think in general that's fine. The problem with spondylolisthesis is that um, it's an instability. It's a mechanical issue. It's something moving too much in the back. So, if the chiropractor, again, we treat the patient, not the images. And so if the chiropractic care, I think, makes you feel better, I think that's fine. But I don't think it's not going to correct the problem. But if your symptoms get better, then that's really all we're interested in.
Thank you.
Yeah.
Here's a question. Once a laminectomy is performed, what are doctors looking over time to decide if a fusion is warranted? I don't know if that's too specific.
No, yeah. So what I look at is, so if somebody's had two laminectomies and they develop recurrent stenosis, and so, theoretically, unlikely that it's central stenosis if you've had a laminectomy or two laminectomies, but certainly that can happen if you have a disc herniation or things like that. Um, and so we talk about a fusion if I think if you have to go back in there and have more decompression done, sometimes that will require us to remove so much bone that it's unstable, and that would require a fusion to fix.
Thank you. Question just came in. I don't think there is, but is there any way to prevent arthritis in the spine?
No, I mean, like I often say to patients, this is a disease of the living. And what I mean by that is that, like, I think at some point we'll all wear out and it'll catch up with us. But uh, being more active, healthy choices, keeping a low body weight, those are all things we can do to try to minimize it. But nothing will prevent it from happening.
Thank you. Um, Maybe we have time for one more. Let's see. Sorry. Let's see. Oh, this is one from a little while ago. And I don't know. You tell me if this is a good question to answer. Do you have an opinion that you can share in the viability of biologics for disc repair, or is this outside of your discipline? This person asks.
Um, so I think I think it's a fascinating area of science that is, um, we're working on it here, to be honest, in trying to figure out disc repair and different ways to try to help make less infusions and make people's backs healthier without having surgery. I don't think, in my experience in dealing with patients who've had biologics, the success rate is very high at this point in any of those treatments, whether it be PRP, stem cells, or any of the other treatments that are out there. I haven't found them to be very effective, but I have found them to be very costly for patients. I think it's a area of evolving science that I think we're all hoping someday will be figured out. But right now, I don't think there's anything extremely viable from that regard, from a biologic standpoint of trying to help regenerate the discs or repair the disc.
Okay. All right. Well, thank you. We're just about at 5 o'clock, so you answered a ton of questions. So thank you. Thanks everyone for logging on tonight. Thanks, Dr. Mangan, for the very informative presentation. We did record this, so we will be sending it out. A couple questions about that. Everyone who logged on and everyone who registered but wasn't able to get on tonight. So we'll be sending that out by the end of the week. You all have my email address, so if you are interested in making an appointment with Dr. Mangan, I know he'd be happy to see you at any of his locations. Again, he sees patients in Bluebell, Limerick, and Glen Mills. Feel free to reach out to me directly, and I can help you get set up. But thanks again. Thanks, Dr. Mangan. Everyone have a great night.
Thanks a lot, everybody. Have a great night. Thanks, Natalie.
Bye.